Alright guys, so now that y'all have had a chance to take a break, we're going to pick up with how our readings may be inaccurate when utilizing a pulse oximeter. If your patient's in shock or has been exposed to carbon monoxide, anything like that, can cause alterations to it. Shock or hypoperfusion states that a patient may be in will cause inaccurate readings due to the poor perfusion status of the patient. They're not getting enough oxygen to the periphery because blood is being shunted away. Hypothermia will affect it also because the extremities being so cold, it's reducing peripheral perfusion and limiting the blood available within the capillaries to be read by the probe. Excessive movement of the patient will also lead to inaccurate readings due to artifact, as well as nail polish on the finger not allowing an accurate reading to be provided. Red nail polish is actually one of the worst nail polishes for the patient to have on. If they do have nail polish on and you're really needing to get that pulse oximeter, you need to have nail polish remover to remove it. Carbon monoxide will give you an inaccurate reading as well, because remember, when you check a pulse ox, it's not measuring the amount of oxygen that is actually within the body. It's measuring how saturated that red blood cell is. It cannot tell the difference between oxygen or some other substance. So if your patient has carbon monoxide within them, which has a higher chance of being absorbed into hemoglobin, it's going to give you a false high reading. Smokers are also viable at this because carbon monoxide is a byproduct of the smoke. Anemia may also produce erroneously high readings. The hemoglobin may be saturated with oxygen, but the anemic patient has decreased levels of hemoglobin. The hemoglobin is saturated with oxygen, but the combined hemoglobin-oxygen content of the blood is inadequate. To acquire an SpO2 or pulse ox reading, if you have a monitor that the sensor has to be connected, make sure that you connect the sensor to. Make sure that you have the proper probe for what you're wanting to do, whether it is a fingertip, one for the ear, whatever. Attach the probe to where you're measuring, whether it be a fingertip or a toe in an infant. Turn on the device if it has not already, and when it starts picking up the pulse, when it's measuring the SpO2, because a lot of these will also read the patient's pulse, you want to be palpating that pulse as well to ensure that you're getting an accurate reading. If you do get a poor signal or an error reading is indicated, make sure that you check the probe to be sure that it's on properly. If there's any nail polish on the fingernails, you need to remove the nail polish or attempt changing the probe to another fingertip. If the ambient temperature is cold or the extremity is cold, it may be useful to wrap the extremity in a warm blanket to provide a better reading. Once you've obtained an accurate SpO2, if you have an unstable patient, you want to reassess every 5 minutes and every 15 minutes in a stable patient. Now, when it comes to blood pressures, your first blood pressure should always be manual. Alright, you're actually putting your stethoscope on, you're taking a sphygmomanometer, and you are physically assessing that blood pressure. Now, once we've gotten that one, once we get in the back of the truck, we'll probably put them on the monitor, where we're actually having the monitor get the blood pressure. With these, it's great because we can set it to a certain interval, whether it be 5, 10, 15 minutes, whatever, and it automatically checks it for us. You can also, because you can print out the roll or print out the log, you can set limits on these monitors to where if it goes above a certain point or if it goes below a certain point, it'll set off an audible alarm for you. Now, why should you... Never mind. Scratch that. To obtain a non-invasive blood pressure, first, make sure you explain the procedure to the patient. We always want to let them know what we're doing. Make sure you apply the properly sized cuff, just like when doing it manually. When using a monitor, you want to make sure you're using the correct size. Turn on the device. Once you are ready, there should be a inflate, activate, read, NIBP. Make sure you know your equipment, and it will activate the device, and it will begin to inflate. Then it will slowly deflate, and once it's completed, it will give you a systolic and diastolic blood pressure. So as you can see with this monitor, you have your on-off button, and here's that start button, and you can even hit it to auto to where it will automatically give you your pulse or check your vitals. CO2 is a byproduct of cellular metabolism. It is transported by the venous system to the right side of the heart. From there, it is delivered to the capillary beds of the lungs so that the CO2 can then be offloaded to the alveoli and exhaled. With normal cardiovascular and pulmonary function, there is a relatively reliable correlation between the EtCO2 or end-tidal CO2 and the PaCO2 or the concentration of CO2 in the arterial blood. Capnometry is the process of monitoring the carbon dioxide that is exhaled from the body. So like I was saying, capnometry is that measurement of expired CO2, whereas a capnogram is when you're actually seeing a visual recording through a waveform. So a lot of times when we're in the truck, if you have a medic on board, we're doing waveform capnography, and even with capnometry as well. So we're doing both of them at the same time, where we're able to see a wave of the CO2 as well as a numeric title of the CO2. Now, there's some reasons that your patient's CO2 reading may change. Some of the possible reasons for changing the CO2 level are normal, they will decrease below normal, indicating there's less carbon dioxide in exhalation. If there is a rise in alveolar ventilation from hyperventilation, the end-tidal CO2 level and reading will increase above normal if there's a reduction in alveolar ventilation due to hypoventilation, indicating that each exhalation contains a greater amount of carbon dioxide. If there is a decrease in cardiac output, a decrease in blood flow, or perfusion of the pulmonary capillaries, or a decline in metabolic activity, the end-tidal CO2 level and reading will decrease. The end-tidal CO2 level and reading will increase if there is an improvement in alveolar ventilation, because each exhaled breath will then contain more carbon dioxide. If metabolic activity suddenly increases, or if there is an improvement of perfusion of the pulmonary capillaries, it will cause an increase in end-tidal as well. Also, if there is a sudden increase in the end-tidal reading in the cardiac arrest patient, it likely indicates the patient has regained a pulse, which is referred to as a return of spontaneous circulation, or ROSC. Even though due to arterial vasoconstriction, you might not be able to detect a pulse. End-tidal CO2 is used to monitor the effectiveness of chest compressions in cardiac arrest. A decrease in the end-tidal CO2 level and reading usually indicates compressor fatigue. This produces ineffective chest compressions and poor cerebral and coronary artery perfusion pressures. End-tidal is also used to confirm and monitor correct endotracheal tube placement. A sudden decrease in end-tidal CO2 levels and reading likely indicates a displaced endotracheal tube. When arriving on scene, you will frequently encounter patients and family members who are frightened, injured, anxious, or in shock. In addition, you may find an angry or hostile crowd and law enforcement or fire department personnel anxiously awaiting your arrival. You must display confidence, and compassion through your personal appearance and professional manner to obtain cooperation not only from the patient, but also from others at the scene. Once you make contact with the patient, attempt to reduce their anxiety and that of others at the scene. You can do this by employing the following simple techniques. As quickly as possible, bring order to the environment by asking that televisions or radios be turned down, dogs be removed from the area in which you are working, and children be supervised by a family member, police officer, or emergency medical responder. Introduce yourself. Ask for the patient's name. Address older individuals formally as Mr. Jones or Mrs. Smith to avoid any implication of disrespect. If time or the situation permits, you can ask, "What would you like me to call you?" Your body position and posture are forms of nonverbal communication. Position yourself at a comfortable level in relation to the patient. If eye levels are equal, so is the authority. If you are standing over the patient, you are in a dominant position of authority and control. This may be uncomfortable for the patient and may set the wrong tone for the scene. However, depending on the scene, when you need to establish control, this position may be warranted. As much as possible, try to maintain eye contact with your patient to help establish rapport and to convey your sincere concern. Speak calm and deliberately to allow the patient to process the information. Raise your voice only if the patient appears to be hearing impaired, and do not always assume that they are. The scene of an emergency is a very stressful situation. The patient, family members, and bystanders may not be at their best. They may seem quarrelsome, petty, rude, or hostile. As a professional, you must resist yielding to the same stresses. Touching the patient is a powerful comfort measure when dealing with most people. Use eye contact to avoid the patient's perception of the touching as encroachment. Hold a hand, pat a shoulder, or lay your hand on a forearm. It is difficult to conduct an assessment, gather information from the patient, and provide emergency care at a scene that is not controlled. The greater the distractions at the scene, the higher the anxiety level of the patient, family, and bystanders. It is also important to recognize when a scene cannot be adequately controlled. It may be impossible to gain scene control when the crowd is extremely hostile, the family is emotionally charged or upset, threats are being made towards you, or the scene is unstable because of the risk of fire, explosion, or any other hazard. You must consider your own safety when working in an uncontrolled environment. If ever you feel like the scene is becoming unsafe, get out and call for police. Information gained in the history is as important in most medical cases as the information determined through the physical examination. The history typically begins with determining the chief complaint. The chief complaint is the reason why EMS was called to the scene. You will continue with obtaining information about the present illness, significant past medical history, and the current health status of the patient. The information gathered may provide direction for the physical examination. Often, the history and physical examination are conducted concurrently, depending on the resources at the scene and the condition of the patient. Once the chief complaint is obtained, you will proceed with a history of the present illness. This is a more detailed evaluation of the chief complaint and associated signs and symptoms. Other components include demographic information, current health status, and past medical history. Certain data is collected for statistical record keeping and demographic purposes. This data includes the following, such as date, time, and identifying data such as the patient's age, sex, and race. Be sure to place the correct date, so that way information provided by the patient regarding complaints, signs, treatments, and any other pertinent information is documented properly. Individual health status factors to consider are current medications, including prescription and over-the-counter, any allergies to medications or substances, including specific reactions experienced in the past, any tobacco, alcohol, or drug use, and how much of the product do they use, their diet, including daily food and drink intake, any screening tests that they may have done recently, as well as any immunizations against certain diseases that they may have taken in the past few months, any environmental hazards the patient may have been exposed to, and the use of safety equipment such as seatbelts and bike helmets in the event that that's the case, and the family history if time permits, especially for diseases with a hereditary link. When preparing to take a history, document the information the patient provides as accurately as possible. It is typically impossible to remember all the information the patient provides, especially when you are doing multiple calls back to back. There are basically two types of questions that we use to gather a history: open-ended questions and closed-ended questions. An open-ended question requires the patient to respond with a descriptive or more detailed answer, such as "How are you feeling today?" or "Can you describe the discomfort?" are examples of open-ended questions. The patient is unable to provide just a simple yes or no answer to open-ended questions. Closed-ended questions is often a rapid-fire type question that requires only a yes or no answer. Are you having pain in your chest? And do you feel lightheaded are examples of closed-ended questions. Often both types of questions are used throughout the history. A multiple choice question that uses a mix of both formats may also be used. When are you more short of breath? When you lie flat or when you sit up would be an example of a multiple choice question. There are techniques that you can use to ensure that you are actively listening to your patients, such as facilitation, which is maintaining eye contact with the patient in a sincere manner. Use posture, actions, facial expressions, or cues, or even words, while listening to help your patient feel more comfortable, open up, and provide more information. Phrases such as "I'm listening" or "go on" may be used. Repeating the patient's words will encourage them to provide additional responses. This is reflection. Avoid interrupting the patient's train of thought while practicing reflection. This may encourage the patient to reveal information you might not otherwise have discovered. The patient states, "My belly hurts," as a response to your open-ended question to gather the chief complaint. "Your belly hurts," is your response. The patient then states, "Yes, it has hurt ever since I haven't had a bowel movement for the past week." Your response is, "You haven't had a bowel movement for a week?" The patient then responds with, "No, it has been more than a week and my belly began hurting a few days ago." As you can see, the chief complaint has changed its focus from abdominal pain to a possible bowel obstruction. We may even use clarification. When we use this to clarify ambiguous statements, responses, symptoms, or words. The patient states, "I feel bad all over." You then clarify by asking, "Can you describe what this bad feeling feels like?" The patient responds with, "It feels like pins and needles in my arms and legs." The clarification technique provided a much more descriptive symptom. We may also show empathy through verbal responses and gestures, such as "I understand," or "I see how that would be difficult," are some verbal responses that show an empathic response. Confrontation, this is sometimes patients do not provide the entire truth or try to downplay symptoms. You may need to confront them to determine the accurate information. You said you've never been to the doctor, but there is prescription for glucophage and your name on the table would be an example of a confrontation. Interpretation takes confrontation to the next level. You may need to make an inference based on your observations. As an example, you say you've never been to the doctor, yet you have a prescription medication in your name. Are you afraid your current medical condition is worsening and you might have to be admitted to the hospital? These are all techniques that will help you in getting everything that you need for that history. We also have a standard approach that we use to obtain our history. Signs are observable physical signs of illness or injury. Symptoms cannot be observed and must be described by the patient. So we have a mnemonic that we use, such as SAMPLE, which stands for signs and symptoms, allergies, medications, past pertinent history, last oral intake, and events leading up to the present illness or injury. Signs are any objective physical evidence of medical or trauma conditions that you can see, hear, feel, or smell. For example, you can hear stridor, you can see bleeding, and you can feel skin temperature. Symptoms are conditions that cannot be observed and must be described by the patient, such as pain in the abdomen or numbness in the legs. You then want to determine whether the patient has any allergies to medications, food, or environmental agents such as pollen, grass, ragweed, or molds. Ask about the type of reaction to the allergen, such as a rash or wheezing. Then you want to find out if the patient has taken any medications recently. Are they taking any medications regularly? It is important to determine whether the patient takes 1. Prescription medications and non-prescription or over-the-counter medications, birth control pills, illicit drugs, herbal medications, erectile dysfunction drugs, another person's prescription medication, or vitamins. You then want to find out what their past pertinent history is. Find about any underlying medical problems that they may have, such as seizures, heart disease, or diabetes. Ask if there have been past surgical procedures or trauma, and whether the patient is currently under a doctor's care. We then want to find out when the patient last ingested a solid or liquid. Find out what it was and when it was consumed, and the quantity that was consumed. Ask when did you last eat or drink. And then we want to know what occurred before the patient became ill or had the accident. Were there any unusual circumstances, and what were they doing? Did the patient have any peculiar feelings or experiences? We also have another mnemonic that we use to help evaluate signs and symptoms that goes by OPQRST, which stands for onset, provocation or position, quality, radiation, severity, and time. Onset is when and how did the symptom begin. We want to ask the patient if the onset was sudden or gradual. Also determine whether the onset was associated with a particular activity. Provocation, palliation, or position means what makes the position feel better or worse. In what position is the patient found? What position makes the patient feel better? A patient complaining of chest pain may tell you that walking up the steps made the pain much worse. Or a patient complaining of dyspnea states, when I lie flat in bed, I can't breathe. Determine whether the patient has taken any medication to attempt to relieve the symptoms. A patient complaining of abdominal pain may have taken an antacid. If something was taken, determine whether the symptoms were relieved, made worse, or remained the same. Also, pay attention to the position the patient was found in because it can provide clues to the condition. Quality, or how would you describe the pain? Quality is most often associated with a complaint of pain. Ask the patient to describe the pain. Most often, pain is described as crushing, aching, dull, stabbing, knife-like, crampy, gnawing, burning, or tearing. Do not ever lead the patient into a certain description of pain. Radiation. Prior to asking about radiation, it is necessary to determine the exact location of the pain. Ask the patient to point to the pain with one finger. Then you can ask them if the pain goes anywhere. The pain is localized if you can isolate it to one area. Generalized pain cannot be localized and is spread over a general area. From the point of the initial pain, ask if the pain extends, moves, or radiates. How bad is the symptom would be the question that we ask for severity. Ask the patient to rate the pain on a scale of 1 to 10, with 10 being with the most severe. Have the patient compare the pain with a previous condition he may have suffered that involved pain. The patient's appearance should give you some indication as to the severity of the pain. Time. How long have you had the symptom? Determine whether the symptom has been present for minutes, hours, days, weeks, months, or years. If you get called to the scene and find a patient complaining of a symptom that has been present for more than a day, ask the patient, without appearing to be judgmental, "Why did you call us today?" Now this is the difference between onset and time. Time is how long that they've had the symptom, such as 2, 3, 4 months. Onset is how long has the severity been going on that you decided to call 911. It may be necessary to ask questions in the history that you might consider to be sensitive in nature, such as alcohol or drug use, physical or sexual abuse, or sexual history. When asking questions that may be sensitive, remain non-judgmental and ask only questions that pertain directly to the medical history and are necessary to gain answers that are pertinent to your assessment and emergency care. Respect the patient's privacy and ask questions of a sensitive nature at the appropriate time and in an appropriate location. Always make sure that you remain within your scope, and if needed, move the patient to the ambulance so that way you're in a more private area. Typically, as you become more experienced and build a solid technique for history taking, the challenges you come across become easier to manage. Some of the challenges are silence, because silence can be uncomfortable for both you and the patient. Attempt to determine why the patient has become silent. Watch their body language for nonverbal clues such as crying, facial expressions of anger, confusion, or depression. A closed body posture and signs of being tense. Try to determine the cause for the silence, rectify it if possible, and proceed with the history. If you have an overly talkative patient, because some patients that we see love to talk and will not allow you enough time to ask follow-up questions. Give your patient a free rein for a period of time to talk and express themselves. But if they become too much, you may have to wheel them in. Some patients present a multitude of complaints. The challenge is attempting to determine the true chief complaint. Asking, "But why did you call today?" or "What was the primary reason for calling us today?" may assist you in determining the actual chief complaint. Many patients also experience anxiety in an acute emergency. The patient may exhibit many nonverbal clues such as sweating, trembling, or nervousness. Encourage the patient to freely express their feelings of anxiousness or anxiety. Anger and hostility are a natural part of illness and injury. Because you are likely to be the first medical person to provide care for the patient, it may be that the patient or family directs the anger toward you. They are not angry at you, even though it may appear that way. All you can do is just try to remain calm, confident, professional, and confident. The most significant concern with an intoxicated patient is your own safety. An intoxicated patient may suddenly change their behavior and become quite violent. Always remain vigilant when dealing with an intoxicated patient. The easiest way to deal with this patient is not to challenge, but to accept them. Crying is a nonverbal clue to the patient's emotions. Be patient, empathetic, and supportive. It's okay to allow the patient to cry. You're also going to come across patients who are depressed. With these patients, we want to look for those signs, such as weight loss, flat affect, poor eye contact or loss of appetite, fatigue, or complaints of aches or pains. Listen carefully to the patient and remain non-judgmental. If there are signs of serious depression, such as thoughts of suicide, be sure to get the patient the assistance and care that they need. A patient who presents with a confusing history or bizarre or unusual behavior may be suffering from a mental illness, dementia, or delirium. Dementia is associated with a gradual decline in the mental status of the patient due to some type of neurological disease. Delirium is an acute alteration in the mental function of the patient that is usually due to a reversible cause. You're also going to come across patients with limited intelligence. The patient is often able to provide you with adequate history information. Be alert to possible omissions of information. If the patient has a severe cognitive impairment, obtain the history from the family or caregivers. If the patient speaks a language that you are not fluent in, try to find an interpreter such as a family member. Realize that some history information may be confused or lost in the translation. If a translator is not available, contact a telephone translation service or transport the patient and notify the hospital of the need for a translator. Hearing impairment offers many of the same challenges as a language barrier. The advantage in this situation, however, is that you can revert to writing to ask questions and obtain information. When speaking to a hearing impaired person, face the patient and look at them when you speak. Such patients often read lips. Use a person who can sign as your translator if available. Remember to tell the visually impaired patient everything that you are doing. These patients cannot see your movements or hand gestures. Thus, you may increase their anxiety significantly if they are not continuously made aware of what is happening at the scene. So constantly communicate with the patient. Some patients are only able to provide limited information. You may need to rely on family members or friends to fill in the gaps or provide the entire history. Family or friends may be useful in providing information about the events leading up to the emergency. With pediatric patients, they present a special challenge based on the ability to understand the questions you're asking. A child may not have the ability to respond appropriately. Once the child reaches 4 years of age, they should become the primary source of the history. Use the parent or caregiver to fill in the gaps. The elderly patient may have physical limitations such as impaired sight or hearing that make history gathering a challenge. However, it should not be automatically assumed that these exist. Do not assume that an elderly patient suffers from dementia. If mental impairment seems evident, ask family or friends whether this is the patient's normal presentation or whether it may be a result of the current medical condition or emergency. Normally, the elderly patient should be the primary source for the information. Alright guys, that concludes chapter 11. Make sure that you're knocking out your Brady labs and preparing for your examinations. If y'all have any questions, please shoot me an email or send me a message in Remind, or make sure that you write it down so that way you can bring it to us next time we're in class. If y'all don't have anything else, I will see y'all later. Bye.